Welcome to the show. This is A review article in Pediatric Emergency Care reminded us of the dangers of e-cigarettes. The toxic dose for children being 1 milligram per kilogram, and e-cigarette fluid containing up to 35 milligrams per milliliter. So you do the math. I heard everything on the internet was true, but the British Medical Journal doesn't think so. They looked at internet diagnoses from websites such as WebMD, and they found that they were correct only 34% of the time, and that they left out the correct diagnosis 42% of the time. Don't believe everything you hear. You know, I get a lot of fan emails and letters, but I found this one particularly interesting. This is from a Dr. Jack Groh of Cartersville, Georgia. He wrote to me to remind me that the American Journal of Radiology has a new study that found that an Alvarado score for acute appendicitis, less than 5, accompanied with an indeterminate ultrasound, meaning that the appendix was not visualized, still had a negative predictive value of 99.6% for acute appendicitis in children. So, Alvarado scored up. Thank you for your fan email. Now let's get on with the rest of the show.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. You know, got his wrist pain by doing over-aggressive high fives to his buddies.
A pericardial effusion can be visualized best from the subcostal window, looking through the liver. An effusion will look like an anechoic stripe surrounding the heart in this location. Here's an example of a small pericardial effusion. In this particular effusion, there's no evidence of pericardial tamponade, which is, of course, the thing we are most concerned about, and the reason for performing a pericardiocentesis. Pericardial tamponade can be visualized on ultrasound, but it's not 100% sensitive, so if a patient has a good clinical presentation in the presence of an effusion, you really have to worry about tamponade until proven otherwise. When we think about pericardial tamponade with ultrasound, there's 3 things that we look for. The first and probably the most important is right ventricular collapse. This is an example of right ventricular collapse from a pericardial effusion causing tamponade. Here we see the free wall of the right ventricle is collapsing during diastole. The next thing we look for is the presence of a collapsed LV. So we think that if the patient has a reduction in forward flow because of collapsing of their right ventricle, the LV is therefore not filling. This makes the LV hyperdynamic, meaning that the walls touch during systole. So this patient, for example, has an ejection fraction of approximately 100% because the LV walls are touching during systole. This is because the LV is not filling appropriately because of the lack of forward flow coming from the right side of the heart. The last thing we're looking for is a dilated IVC. If someone doesn't have appropriate forward flow because of lack of filling of the right side of their heart, we expect the blood to back up into the inferior vena cava. To look at this, we're looking at a subcostal window. This is a subcostal long axis window, and you see the effusion here. Here we see the liver, and the IVC is nice, fat, and dilated, and not collapsing at all with respiratory variation, telling me that there is a significant reduction in forward flow. To perform a pericardiocentesis with ultrasound, you're going to need a couple of things. The first and most important is obviously the ultrasound machine, and we can use either the curvilinear abdominal probe if we're performing a subcostal technique, or we can use the thoracic probe or the cardiac probe if we're performing a apical technique or with the subcostal technique. Of course, you'll also want a pericardiocentesis tray. Now, you don't have to have one of these. If you're not placing a catheter, you can simply use a spinal needle and a large syringe. However, if you do want to place a catheter, I recommend you keep a pericardiocentesis tray in your emergency department. There's two particular windows that we use when we perform a pericardiocentesis under ultrasound guidance. That's the subcostal window, which is the more classic window, performed usually without ultrasound guidance, and then the apical window, which has gained a good bit of popularity since the use of ultrasound for guiding this procedure. Some people also use a peristernal technique going in the third or fourth intercostal space. However, I prefer not to use this due to the location of the left anterior descending artery. The concept of lacerating that artery just sort of scares me. This is an example of performing an ultrasound-guided pericardiocentesis from the subcostal window. The steps that we mention here are pretty much the same steps that you would use for the apical window, the only difference being the orientation of the ultrasound probe. For this particular example, we're using a curvilinear abdominal probe. However, you could also use the thoracic or phased array probe for this particular image. Here we see we're looking at a heart with a fairly significant diastolic collapse of the right ventricle and a fairly large effusion. We're going to be coming through the liver here, and we're actually visualizing the pericardium through the liver here. I'm going to insert the needle just lateral to the probe to the patient's right side. That way I'll be going through the liver and towards the patient's pericardial sac. As I insert the needle and draw back, I'll get a flash of blood into the syringe. Once I've seen this blood, I'm going to confirm that it appears my needle tip is in my pericardium. After I do that, I'll take the syringe off, and I'll place a wire through the needle into the pericardial sac. Again, confirming that the wire is in the pericardial sac and not the ventricle. I'll use ultrasound for this confirmation. Then I'll slide a dilator over the wire, and finally pass a catheter over the wire and remove the wire. At this point, I can place the wire to downdrain to drain the pericardial effusion. Here's an example of a real-time performed pericardial effusion. Here we're using the phased array probe from a subcostal window, and you can see the needle coming in just about right here. We see we've popped through the pericardium, and once we pop through the pericardium, we're going to start advancing our wire down. You can see the wire pushing down on the right ventricular free wall here as it goes into the pericardial sac. After the wire, we'll of course push the dilator over the wire. Here we see the dilator coming in. And then finally, the catheter will be placed over the wire into the pericardial sac. Once the catheter is in place and it's hooked up to downdrain, you can actually see the pericardial effusion diminish in size. And here we can see that pericardial effusion getting much smaller. In addition to the subcostal window, you can also use the apical four-chamber window. For this particular window, I'll again place the needle just lateral to the probe. However, this time I'm going to come from a medial orientation directed towards the apex of the heart. I'll again be able to see virtually the same thing that we saw with the last image. However, we'll of course use the phased array probe in this instance because it's much easier to visualize through the rib spaces with a phased array probe rather than with a curvilinear. A few tips and tricks. So agitated saline is a great technique for making sure that you're actually in the pericardial sac as opposed to placing the needle or the wire into a ventricle. Here's an example of injecting agitated saline into the pericardium once you have the needle in what you believe is the pericardium. You can see how the agitated saline lights up and is extremely hyperechoic in the pericardial sac here. If we were inside a ventricle, say the left ventricle for example, we would see the left ventricle light up as opposed to remaining dark here. Agitated saline can be a great way to confirm that you're in the right location, especially if you're trying to tap a small pericardial effusion or if you're just not very comfortable with placing a large dilator into a ventricle. Needle in plane technique. Some people talk about using the needle out of plane technique, which would mean going with the needle through the center of the probe. However, I prefer having the needle come in laterally so that we have the needle in plane and in view the entire time. This allows us to see the needle tip and really know where it is in space. So I'll have the needle come in just lateral to the probe, and then that way I know where to expect it on my screen. I would expect the needle coming in just here laterally, going towards the pericardial sac. Again, I'm going to have the needle actually come in right next to the probe marker. That way I know to expect the needle coming from the probe marker, as seen here. Go where the fluid is. It's important to remember that with pericardiocentesis, there are no margin for error as possible. So wherever the pericardial effusion is the thickest is probably where you should go with your needle. If that happens to be peristernal, even though Malin said don't do it on his little podcast, go for it. Whatever you think, whatever you're most comfortable with. So apical, subcostal, peristernal, wherever that effusion is the largest is probably going to give you the best chance of success without taking out a ventricle and placing a catheter in someone's aorta.
Some good news and some bad news. The bad news is we only have a couple spots left for Castle Fest.
So since it's obvious that some people are not going to get to come who want this education, we found a solution.
Yeah, here's the good news. We're investing in some technology to allow us to stream the whole conference live. All the lectures will be streamed in high quality in real time, so you'll still be able to get a full 16 hours of CME.
And you don't even have to come to Kentucky, hang out in the castle, go to the bourbon distillery, watch horse racing, and all that nonsense. You can attend via the comfort of your own home.
Actually, you could even watch while at work or while driving in your car. It's going to be streamed live and completely mobile, so you can watch live on your iPhone, your Droid, your iPad, or whatever device you crazy kids have nowadays.
To sign up, go to ultrasoundpodcast.com or castlefest2013.com, and there will be buttons for the virtual attendance.
Now, Mike, that's great, getting to watch while jogging, biking, or sitting on the toilet, but I just thought of something. They won't be able to ask questions and interact with the speakers. What if they've always wanted to ask Weingart what mic setting he uses to sound so smart, sexy, and hammer time cool all simultaneously?
Come on, Matt, we're better than that. Of course you can. We're going to have feeds set up live so you can ask questions in real time, and we will have people responding to them or raising their hands to ask the speaker questions.
So I can ask that stupid question I'm always afraid to ask in person, and no one will know who Bieber fan number 1 is?
That's right. Ask away. Anonymity is nice.
All right, I'm sold. I'm going to attend virtually. I've always dreamed of doing jazzercise and watching Mike Stone teach nerve blocks at the same time. How do I do it again?
Go to ultrasoundpodcast.com or castlefest2013.com and sign up for virtual attendance. There are a few different packages to choose from, all guaranteed to delight.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.